Welcome everyone to our inaugural 2025 webinar series. We have the pleasure of having Dr. Victor Montori with us here today. Before I talked a little bit about Dr. Montori, I just want to take a minute to acknowledge, if you want to go Jessica to the next slide. I just want to take a minute to recognize that Passerelle has offices across Canada and have collaborators across Canada, but our central office is situated on what is known as Quebec City, on the traditional unceded territories of the Huron-Wendat people, Innu, Maliseet, Atikamekw, and Abenaki people. So in the spirit of respect and reconciliation, we extend our gratitude to these nations for their stewardship of this land. In addition, as we work toward a research future that's more inclusive and puts the patients and the public at its center, let us also make that commitment to educating ourselves about the rich Indigenous heritage that helps shapes our collective journey. Let us move forward together by embracing the wisdom of the past to create a better tomorrow. I also want to mention that our upcoming webinar on February 12th, if you want to put this already to your agenda, we will be hosting Stephanie Bartlett, who is a consultant at the Wentland School of Education, and will be presenting on collaboration of the unplug, how belonging and relationship can enhance our research teams. So back to today. So welcome, Dr. Montori. Welcome, Victor. Thank you so much for joining us today. Dr. Montori, I could talk about Victor for an hour just to say how amazing he is and the work that he's done. But let me just mention that he is the Robert H. and Susan M. Redwald Professor of Medicine at Mayo Clinic. He's also an endocrinologist, health services researcher, and care activist. Victor is the author of more than 700 peer-reviewed publications and is among the most cited researcher in clinical medicine and social sciences. He is a recognized expert in evidence-based medicine, shared decision-making, and minimally disruptive medicine. He works at the Mayo Clinic in Rochester, Minnesota, at Mayo Clinic's Knowledge and Evaluation Research Unit, where with his amazing teams work to advance person-centered care for patients with diabetes and other chronic diseases. If you haven't read it, I strongly recommend it, but he is also the author of the book, Why We Revolved, and is leading the movement for a patient revolution for careful and kind care for all, and is, full disclosure, also a mentor of mine. So thank you again, a mentor and a friend who agreed to be here with us today. So thank you, Victor, for this. And on that, on to you. Thank you.
Thank you very much, Professor Leblanc, and I am delighted to be here. Can you hear me okay, and can you see my slide? Yes? Okay, wonderful. So this slide has my email address, so if you okay, too fast. If you need to reach me with any comments or questions or any problems or issues that may arise that we didn't get to resolve during the call, feel free to connect with me this way. And I usually have a disclosure slide. I am at the Mayo Clinic. That's where I'm a salaried clinician there. Our research group does not take any funding from any for-profit corporation. And I will talk about some things that we're doing with the Patient Revolution, which is an organization that I co-founded almost 8 years ago. And I'm the chair of the board. I'm a volunteer. I don't derive any income from that or from the book Why We Revolt, which I wrote, and all the proceedings of that book go to the organization. So all my funding is as a researcher and clinician at the Mayo Clinic. Um, this graph I find is very, very helpful to frame our conversation. And it shows all the ways in which, not all the ways, but all the main ways in which healthcare addresses the problematic situation of patients. Cure is perhaps the most common way by which we think about how do we get the right treatment, the right cure to the right patient after making the right diagnosis? How do we deploy that treatment correctly at the right time, the first time, with the right expertise and equipment? And a lot of the health services research, the evidence-based practice initiatives, the knowledge translation work, and the quality improvement movements are predicated on this idea that evidence can find out what the right answer is, and we just have to make sure that it gets delivered to the right people. Um, I was able to enjoy this when I received a cataract surgery on my left eye, the result of trauma to that eye 30, 40 years before. And I was put in a chair, and I went through what felt like a conveyor belt where things were done to me. Eventually, I was pulled back. A surgeon looked into my eye, took out my lens, put a new one in, and then I came out the other side. And from door to door was a 30-minute thing, walking away home at the end of those 30 minutes with, a better vision on that eye. And my surgeon didn't have to develop a relationship with me or with my eyeball for that matter. It only had to be done properly and correctly. And we celebrate this. This is a man who, 10 years prior to this picture being taken, tried to take his own life by a gunshot wound and destroyed his face in the process. Over the next 10 years, received multiple operations and efforts to try to give him enough function until a team of 6 surgeons working in the operating room over 2.5 days after 9 months of planning that involved 80 staff people at the Mayo Clinic and gave him a face transplant. After receiving the face transplant, he's gone on to many news outlets. This has been celebrated as a major accomplishment. And when he was asked what was he going to do now, he talked about forming a family, finding a partner, forming a family, and then dedicating his life to promoting mental health and suicide prevention. So it's interesting that when we have this opportunity to make fixes, to make cures, we there's great effort, great investment, and advertisement and promotion of these feats of medical technology and skill and teamwork. And of course, all of those things must be celebrated. What is not so often celebrated is the small little persistent efforts that healthcare professionals in the mental health area do with people over years to prevent um, um, what led to this man requiring the face transplantation. And that is actually the most common task that healthcare is demanding today, which is how do we respond to the situation of mental and physical health, chronic conditions that are increasingly affecting people. And this is one of several graphs that are in the literature about the epidemiology of chronic conditions, where most people notice how as you age, you accumulate very many chronic conditions. I always draw the attention to the middle of the graph, where the middle-aged person, the average middle-aged person, if you look at the 50% line, already lives with at least one, if not more, chronic conditions. So chronic condition care is the main thing, the main demand on healthcare today, and is where most of us spend our time and most of our patients come in repeatedly for care to our healthcare system. Um, and that is the other side of this graph. And what's happening there is that we are as clinicians, we're managing symptoms, we're mitigating adverse effects of our treatments, we're coping with disappointment, and disappointment is the most common outcome in chronic care. At least maybe for my patients, and preventing complications, rehabilitating sequela, doing self-management support and problem solving, essentially making care fit. Because as opposed to cure, where most of the time the patient is getting care done onto them, in care, it's the patient is actually doing a lot of the care, and it's happening as their life is happening, and they have to sort of weave in the requirements of healthcare with the strands of their complicated life. And as people have more complicated lives, they also end up having more chronic conditions. And people at most disadvantage end up developing those chronic conditions at an earlier age, at a faster clip, and most often accumulating more mental health problems in relation to the physical health problems they're also having. And so this is the type of work that I do clinically. I take care of patients with diabetes and other chronic conditions. And notice that in this graph, when you look at that line, the line doesn't go to the corners. It misses the corners by a little bit. And that is purposeful because when we're curing people, like that face transplant that patient received, there's a whole lot of care that will now be necessary, even though the problem seems to be fixed. This man has to uh, regenerate not only a face, but he has to regenerate a persona that is now he's now able to imagine, because he now can imagine forming a family, having a partner, and becoming a public health, a mental health worker. And so that care to rehabilitate him as a person is going to be essential. Similarly, on the other side, when most of the activities care, occasionally there are treatments that can fix problems. Cystic fibrosis is an important example today, where most of those patients grew up knowing that they will probably not become adults, they will probably not have children, and will be limited in their ability to do sports. And with treatments that have now emerged that are not a cure, but essentially when you're taking the treatment, you're almost completely normal in terms of your functioning capacity. The possibility of living longer lives, having families, and playing sports becomes something real. And so, even though the patients have moved from care to cure, they also have to go back to care because they now have to re-engineer, reimagine themselves, not as a chronically ill person with some limits on what the scope of their flourishing could be, but one in which those limits have been removed. And so, care and cure have to be in our language and in our ability as healthcare systems. We need to be ambidextrous in those two capacities. And here's Maria Luisa, a patient that has been with me for over a decade in these presentations. This picture was taken by Anna, her granddaughter, and it shows Maria Luisa at home and looking at a series of pills that have been prescribed for her. Those prescriptions have mostly arisen from the response guidelines and other protocols to Maria Luisa's situation, particularly her biology, the systems, the organs, the symptoms, the diseases and conditions that she has, the things that actually make her similar to other patients with the same diagnostic labels and allow clinicians to respond to those diagnostic labels in an evidence-based fashion with a series of tablets that are now sitting on her table. And when we respond to someone's biology, we're offering care for people like Maria Luisa with the same biology. But that is not the job. The job is not to take care for people like Maria Luisa when we care for her, is to care for Maria Luisa. And that requires us to not only look at what she has in common with other people with the same diagnostic labels, what she has in common with others with the same abnormal biology, but also to look at her biography. where is Maria Luisa coming from? What adverse childhood events or challenges has she experienced? How has she lived her life to today? Because that gives us insights into how is it that disease and treatment are now interfering with that life, and how might her life be interfering with the safety and efficacy of the treatments that we may be considering, but also looking forward into to her life. How is it that her goals and priorities for the future should affect today's decisions about how we sort out how to respond for her? So we need to move from just responding to the biology to seeing Maria Luisa in high definition and working with her to form plans of care for Maria Luisa that account for her biology, but also for her biography. It also raises issues about why is it that we form healthcare organizations, and we do it to respond to people, to respond to Maria Luisa. But oftentimes we get confused, and in our effort to improve our efficiency, in an effort to reduce our costs, we see patients and their families as a source of free labor, as an untapped resource for healthcare delivery. And we start adding tasks to Maria Luisa and her family, tasks that seem reasonable on their own, or perhaps reasonable to patients who are not engaged in healthcare every day and are coming to a healthcare system frequently. Perhaps they're not so bothersome for someone with an acute condition, but with somebody with a chronic condition, they become like a part-time job. Things such as organizing information, asking prioritized questions, recording the visit, reviewing the medical record, transmitting data through the portal, self-monitoring, self-management, educating themselves, managing appointments, prescriptions, and bills, overcoming bias against illness, class, or identity, keep everyone informed, advocating for herself and others, and to wait. And waiting, of course, is almost like a hallmark of healthcare. It's one of those challenging things where the currency of care is time, and there's always lack of time. But when it comes to the experience of care, it's always waiting that is permeating that experience. And patients and their families learn to wait for appointments, learn to wait in waiting rooms and physician offices, wait for tests to take place and then for results to appear. They wait for the interpretation and for treatment plans to form, and then they wait for the treatments to occur. And all this waiting is in a life that cannot be paused, but it's infrequently interrupted by those waits, and becomes very burdensome and demanding of the capacity that people have to respond to that. And when they can't mobilize that capacity, and when they have to, for living their life, having to skip some aspect of their medical care, the response from us in the healthcare system is often to label the patient, not their situation, but the patient, to label the patient as non-compliant or non-adherent, as lacking personal responsibility for their own improvement, as not being a good partner in our effort to improve their outcomes. And when that non-compliance or non-adherence affects outcomes that are being monitored as a marker of the quality of the healthcare that we are offering, or as a marker of our reputation, or even as a component of our financial reimbursement, Maria Luisa becomes the enemy. What I just described is industrialized healthcare, a healthcare that feels like a conveyor belt that is helpful for fixing, but contradictory for the efforts necessary for care, in which patients are blurry, are responded with generic interventions that are burdensome and can be sometimes cruel. This is not just cruel for patients, but also for clinicians. This is work from my colleague, Mark Linzer. He was tracking across over 100 practices in the United States, the rate of burnout among clinicians. And this This rate of burnout as the time goes, you can see there's a brownish line in the middle, dark gray line. That is the average burnout rate, which is around 40 to 50%. But that average hides two groups: a group with much higher burnout, being in the order of 75, 80%, and a group with a lower rate in the order of 25 to 30%. And the group with the highest burnout works in environments where they don't feel valued as health professionals, where they don't have the control of their work conditions, which are often hurried and chaotic, and lack the teamwork that supports them through their work. So this industrialized healthcare also creates conditions that are adverse to the work that health professionals must do to respond to the problematic human situation of their patients. So industrialized healthcare is healthcare without care. And healthcare without care is unsustainable. It's unsustainable financially, as every political debate in most developed countries indicates that we can't afford the healthcare system that we have. It's financially unsustainable. It's also environmentally unsustainable, producing give or take 5% of all carbon and the greenhouse emissions to the environment, which is problematic to have a healthcare system causing harm to the health of humans, animals, and the environment. But it's also, and importantly for this conversation, it's important to note that healthcare without care is humanly unsustainable. So clinicians working in this environment, over 70% report moral injury from working in this environment, a profound existential disappointment and a gap between what they showed up to do and what they're able to do, with 40% of clinicians either intending to leave or cutting back their hours or leaving completely clinical practice, which of course breaks the heart of their patients and breaks the back of our colleagues who have to pick up the work that those who have left leave behind. But it's also financially challenging for the systems who lose people, because they have to invest more in the retention of those that remain and in the recruitment of new ones. There's also a problem with the clinical encounter, where the clinical encounter is only about the patient's agenda about 40% of the time, with the rest of the time being focused on the version of the healthcare system of that, which is disease management, completing checklists and things that must be done or should be done, protocols, guideline implementation processes, and data collection activities. When patients get the encounter to be about themselves, is because they speak up, but clinicians interrupt patients' agenda-setting statements within 11 seconds of those statements being offered. And patients themselves, particularly those like Maria Luisa, who live with multiple chronic conditions, are reporting, 40% of them reporting unsustainable levels of burden of treatment, which basically means that they're on the verge of stopping some of those activities, some of which might be incredibly important for the quality and duration of their life. Healthcare without care is humanly unsustainable. These patients with chronic conditions and the clinicians that care for them, I think, function in the healthcare system like the canary in the coal mine. This is a picture from 1986. So this technology to pick up toxicity in coal mines was only recently discontinued, amazingly enough. Coal miners will go down into the coal mine with the bird, with the canary, and if the environment of the mine will become toxic, the canary would not die. In fact, what it would do is it would become restless, and you swing back and forth in the little cage, and fly around and become very restless. But if the toxicity remains, the canary would stop singing. Patients who not show up to appointments, who don't take their medications, clinicians who leave the practice, these are the canaries who have stopped singing, because the environment, the conditions of care that in which they are involved have become toxic to those who work in those conditions and those who repeatedly come and get exposed to those conditions because of their chronic conditions. So if we solve the problems for patients, problems of care for patients with chronic conditions, we might be on our way of making that healthcare system less toxic also to its professionals. So this configures a crisis of care. And the question for all of us in healthcare and healthcare research is how, in healthcare education, is how might we respond to this crisis of care? The dominant culture and language today, which we tried to capture with Iona Heath on this piece in the BMJ, reads something like this. One response is to assume that this is a crisis of organization, of efficiency, of information technology, or of scale. And what we need to solve it is we need to operate at scales of speed and reach that are only possible when organizations and leaders abandon the idea that care is only possible between people. And once abandoning that idea, we start processing people, but that in turn requires more consumption of data, of medications, of technologies, ignoring the consequences for other economic priorities allocated for human flourishing, and ignoring consequences for the planet. What's the alternative? The alternative is to assume that this is a crisis of care in and of itself. That brings our attention to understanding what care is. This is important, but often overlooked because care being such a small word, we end up putting a lot of adjectives around it. We talk about patient-centered care or high-value care or evidence-based care. And in all of these circumstances, what we are doing is really drawing attention to that adjective, to the evidence in evidence-based care, to the value in value-based care, to the patient in patient-centered care. But what about care? So care is a practice, a series of rituals and actions that we do, but it's also a disposition to attend to the problematic situation, in this case of a patient. It involves both noticing and responding. Noticing requires that the person doing the noticing is paying attention, is present, is able to appreciate the situation of the patient in high definition, not just in what the patient needs, but also what strengths they bring into the care encounter, into the care situation. Now, noticing is insufficient. This is where empathy kind of falls short. To notice and to, the pain or the difficulty or the circumstance of the person doesn't actually do anything for that person's ability to be better. So care requires not only the noticing, but also the responding. It's in choosing to respond, is in taking responsibility that we actually create the possibility that the person's situation can improve. And in so, by inventing that action, we give people hope. So care is noticing and responding. And then it's also caregiving and care receiving. And in caregiving is when we mobilize our competence so that we do more good than harm, and our compassion so that we attend to the emotional aspects of the situation to address the suffering of the person, working with that person, not doing to the person, but working with the person. That's the caregiving, but it's also care receiving, which means that the person receiving the care is in the best position to determine whether the response to their problematic situation is pertinent, is adequate, and is desirable. So care is a practice and a disposition, is noticing and responding, is caregiving, and also care receiving. Now, I've discussed for you what I'm calling these pathologies of care, these things that that make our efforts fall short. Seeing the patient as a blur, creating burdensome and generic treatment programs, seeing people in a hurry, and being cruel. These are the hallmarks of industrialized healthcare. And I think we need to move away from this undesirable evolution of our healthcare systems globally towards systems that enable the people working in them to offer careful and kind care for all. And so, how might we do this? The first step is to recognize together that care is healthcare's core purpose. That is the reason why healthcare organizations exist, why healthcare professionals from clinicians, physicians, nurses, all the way to administrators and policymakers. This is why everyone that isn't working in healthcare went into healthcare, supposedly is for care. So we need to cultivate care, and we need to cultivate care at every level. And when we're making decisions about care, when we're shaping care, when we're doing research about care, we need to be able to tell stories about that care and use those stories to drive care in our healthcare system. This is a cultural first step. And so one example of this is as we recognize this idea of fixing problems and the caring and supporting, coping, and adapting for people with chronic conditions as our function, we need to recognize where on the right, where when fixing problems variance is a defect, and we can drive our efforts to correct those defects to make it a highly reliable healthcare system in that way. While on the other side, we need to recognize that variance is a virtue because we are dancing, we are responding to the situations that patients are coming in, and coming in to reduce the variance on the left will create errors, or favoring variance on the right will actually create errors and defects. And so we need to make sure that we know where we are and we're telling the right set of stories to make sure that we don't drive away that variance when that variance is in fact our efforts to make care fit. And we also need to recognize that this is a porous line, and that everyone that is getting cured is going to need care, and that there are opportunities often for cure when we're caring for folks. What is needed then after we intervene on the culture, in the norms and the policies and in the ways we talk to each other, is we need to look at the conditions for care. This is a cathedral by Rodin, and it shows two hands each from a different person coming together, the fingertips almost touching. The palms of the hands are creating that cathedral that he wanted to represent. That's where the action happens in the cathedral. Now, to make that happen, he had to chip away at all that marble that was between those two hands. And I would put forward that that is the next step in our work. We need to radically change the conditions for care, but making sure that patient and clinician, caregiver and care receiver can actually care without being disrupted by the conditions in which they have to work. And that requires us to bring attention to our caregivers. They have to be well and they have to be competent. And we need to attend to both things. We need to foster collaboration and team-based care, not only because that makes care safer and better, but because then in the context of the teams, people can also care for and about each other as they care for their patients. And importantly, as we bring new technologies and innovations into the healthcare space, not only should we look at the cost effectiveness of the financial impact analysis, but we also need to know how are these technologies and innovations going to support or disrupt the care. We need impact on care analysis of these interventions, such as the electronic health record or interventions focused on artificial intelligence. What about these pathologies of care specifically? Well, we can go one by one. If we have patients that we cannot see in high definition, we need to change that towards seeing them in high definition. Burdensome care has to become minimally disruptive. Hurried care has to be focused, has to be transformed into a series of unhurried conversations. And the cruelty of indifference needs to be replaced with responsiveness. How might we do that practically? In terms of seeing people in high definition, there are a number of interventions that different groups around the world are testing and advancing, like routinely asking people and paying attention to the answer, what matters to you? And then letting the answer shape some aspects of their care that are open to be shaped and individualized to respond to the biology and biography of each person. Be curious about patients' lives. We watch thousands of video recordings as part of our encounter research, and we notice that in many instances, it's not the lack of patient engagement that is the problem in healthcare, is the lack of clinician engagement into the life of their patients that is the problem. So we got to have curiosity of our patient's life and be able to have the mental space and the time to be so. And we need to introduce some way of having those biographies front and center as we see people. And that might be achieved, for instance, by highlighting patient biographies in the electronic health record. How might we promote minimally disruptive care? Well, we need to reduce the workload and promote the patient's capacity to do the work of healthcare, but more importantly, to make sure that the work of healthcare doesn't displace the work of life, which is what motivates people to go ahead. And so that means we need to stop transferring work to patients and families. We need to understand better, why are people not showing up to appointments, and what is contributing to their low fidelity to the implementation of our treatment programs. It is that understanding that probably will lead us to improvements in both the way we organize and deliver care, but also in the way we design our healthcare treatments, ideally with each patient. And we need to simplify care and the navigation of the care system. The idea of forming and developing and implementing navigators, of course, well intentioned, but it leaves the system in its complexity intact. And so those who cannot access the navigators will still have to deal with the chaotic and disorganized system in the back end. So simplifying the healthcare system, reducing unnecessary redundancies, and reducing the waste that is transferred to patients and family when they're trying to consume the system will be important. In terms of unhurried conversations, we need to look at the points where patients and clinicians with each other are having those conversations, and make sure that we limit the interruptions, that we limit the distractions. So those conversations don't have to be long, but they are unhurried enough so that people can see each other and they can respond in a thoughtful way by co-creating those plans of care. We need to make sure that our scheduling is responsive to the needs of the needs and the reasons that people have to meet. So if I'm going to have an appointment with the patient, why is this appointment the exact same duration this time as the last time? If today we have a different agenda, if the patient has different needs. And we need to think of, and maybe that would be a good use of artificial intelligence. And we also need to implement and the value of continuity of care. When people have relationships where these are relationships of vulnerability, when people are opening up to each other, when patients are telling us stories that in part involve relieving their trauma, we don't want that patient to then be having to tell those stories again and again and again to different people, when we can instead offer a continuity of care. Continuity of care makes patients and the way they manifest disease and familiar, so it reduces the need for diagnostic testing, and the continuity of care has also been associated with reduced mortality. It's a very difficult from an efficiency perspective for industrialized healthcare to defend continuity of care, to promote unhurried conversations. So, this shift really requires us to leave behind that model of industrialized healthcare. And for increasing responsiveness, we need to eliminate wrong doors. Come on Tuesday, we don't do this on Mondays, go around to the other place. We need to make sure that every encounter with everybody in the healthcare system is an encounter that is contributing to responding to the problematic situation of the patient. I once went to a hospital where I got a chance to meet with the security guards, and I asked the security guards what was their primary goal in the hospital. And they said that their primary goal was to care for the patients. And I was taken aback. These guys had weapons on their belts and uniforms, and they looked like they could beat you up. And so thinking, how are they going to contribute to the care of the patients? And they reminded me that oftentimes when patients come into the emergency room, the first person they'll see is the security guard, and they're scared. The patients are scared and afraid, and they don't know what's going on, and they might be in pain, and they're anxious, and so they could be agitated. And the way their security guard responds to this agitation, to that nervousness, to that uncertainty, sets the tone for the interaction with other personnel behind the door. That might include the patient, the physicians, and the nurses in that emergency room. So his responsibility, or the responsibility of the security guard, is to be the first line of care, not necessarily the first line of defense for the hospital. This is a graph that that I stole from the internet. I don't know where I got it from, but this is someplace around the world where people got tired of standing in line and have their shoes stand in line for them. When healthcare systems just assume that people have time that they can use and spare in waiting, they set up these processes, like in this hospital, that indicate to the patients your time, energy, and attention are not important for us. Just hold and wait. And they can do it on the phone recording, or you can do it in real life, like in this picture. And that, once again, is indifferent to the suffering of these people, and I find it cruel. And one of the things we must do in healthcare is we need to eradicate cruelty, very much like we want to eradicate wrong-sided surgery. So, how do we know we arrived? How do we know that we've been successful? I think we'll know we've been successful when we are able to foster unhurried conversations in which clinicians can appreciate the patient's situation in high definition, where they can develop resilient and longitudinal relationships over time, and when they can form plans of care with each patient, co-creating those plans of care so that they provide a resolution that makes intellectual, that is evidence-based, emotional, and practical sense, is feasible in the lives of people. In other words, care that fits. And there is a manifesto that was published a few years back that contains a line that I think describes what we would like to see happening regularly, routinely in healthcare systems. We want patients and clinicians to collaborate in designing care plans that maximally respond to each patient's unique situation and priorities while minimally disrupting their lives and their loves. That is what we're trying to pursue. Now, one key objection to all this is that there is no time, there are no resources to get a healthcare capable of care. Well, that draws our attention to society, to the community. And while there's been a lot of effort and talk about social determinants of health, at least in the United States, there's been a push towards an emphasis on prevention that is focused on the response at the individual level, the screening, the precision medicine efforts to try to identify early disease in people and respond to them, which of course have made primary care in particular very, very busy and unavailable to many folks in a timely fashion. At the same time, we've abandoned, and after COVID in particular, nearly destroyed public health. And the public health investments in many countries, particularly in the United States, is limited, and is transferring all that prevention effort into the healthcare system. So one aspect that it seems to be necessary as we move away from industrial healthcare is to promote and invigorate a public health investment that will reduce the burden of disease on the population at every age, at every time, and promote healthy living. And as well as environmental health, as we work to try to overcome global warming and the health impact of severe climate and severe weather events. So that is an important aspect, but a critical determinant of health, critical social determinant of health, is how we care for and about each other. And there has been another evolution that has been problematic, which is the notion that for every problem of health, from every source of every form of suffering, the response must be professional. And so the notion that professional care must be the response for every form of suffering is overwhelming our healthcare system and making the mission impossible to meet. And it's also de-skilling the population in their ability to actually respond to suffering of each other, either being emotional or physical. And we don't value that care work that people are doing at home. They're doing with limited visibility, and is often done by women. And it's often done and increasingly done in the Northern Hemisphere, is increasingly done by women of color who are migrants. So that needs to also change. And we need to advance what I'm calling common care, which is the kind of health care that we can give to each other. We need to advance those skills, make sure that we get really good at them. The only skill that we really have invested in doing this way is cooking. So we have, cooking books, and we have all sorts of stores that sell us cooking utensils, and we have cooking shows, and we know we value that particular form of care, cooking meals for other people, because there are now men making a lot of money cooking professionally. But other forms of care don't enjoy that same recognition. And we need to make sure that the tasks of care are democratized, so that if everyone that thinks they deserve to be cared for also need to understand they have a responsibility to care for others, and has a responsibility to develop the skills and be proud of the skills of caring for other people. And I think when we recognize the work of care, when we elevate the work of care, when we develop and advance common care, the need for professional care needs to start collapsing and reducing, and making more likely that our revolution of moving away from industrialized healthcare to careful and kind care for all will be more possible and feasible. And it's urgent, because to care is fundamentally human. The mission, unfortunately, is infinite. And the capacity that we have to care is not. If we have the rights, if we cultivate care, if we have the right conditions for care, if we focus on our ability to care well, care has this magical effect of transforming the lives of people in the healthcare system, but also at home, and enable what we see here in Maria Luisa, that smile. What are we willing and able to do for that smile? Because as caregivers, when we see that smile, we get renewed, and we allow care not only to be an exhausting mission, but also to be a renewable resource. So let me finish by telling you that this revolution is not going to happen by itself. It requires people to focus their energy and attention on this. We have formed an organization, the Patient Revolution. There's the website on the bottom left. That is a home for care activists all over the world who are acting locally and having immediate impact where they are. We call them mini revolutions. But mini revolutions are not going to change the world. So we need to make sure that they come together and they're a community where they gather courage to do these changes, where they can get the necessary support from each other, and where we can learn together what to do and what not to do. In learning, we have also developed a school that offers free courses so people can understand what we mean by care, but also how do we accomplish the necessary changes to bring about this change everywhere. And we have a greenhouse to grow new ideas, to grow new policies, to learn from the best available evidence, to form these ideas and policies, and bring it all together in the service of those care activists that are working at the point of care. One of those products is this book, Why We Revolt, that summarizes some of the ideas I have shared with you today. And then we have a small organization that serves as the administrative and moral backbone for this global movement for care. And I would like to invite all of you to look into it. And if you feel that this is consistent with how you see the world and your life mission, to join us as fellows of the Patient Revolution, so that we can develop a healthcare system that is based on solidarity and not greed, on integrity and not just rules and regulations, on elegance, no hurry and no haste and no waste, but not just on efficiency. That is for this patient, not just for patients like this, that is minimally disruptive of people's lives, and that is based on not on transactional interactions, but on relationships that sometimes are relationships of love. Let's work together to bring about careful and kind care for everyone. Thank you very much for your attention.
Thank you so much, Victor, for such an inspiring talk. So let's open up to some of the questions. So we had a first question here in the chat for you, where time seems to underline all of the problem identified. How do we, as either patients or healthcare provider, or as member of a research teams, could deal with that problem? And I think that
I'm sorry, say that again. I didn't understand the question.
or here's the person says time seems to underlie.
Oh, time. Okay.
Yeah.
Yeah.
So how
Yeah. So that's why at the end, I pointed out that if healthcare's tasks continue to be expanded to account for every form of suffering, that there will not be any time for care. And correctly, time is the currency of care. And I find it um, that we often think, well, yeah, that's fine, but we need to deal with it now. And this calls for heroics, either from patients demanding that the time is spent on them, or for clinicians who choose to make the time to see the patients. The problem with heroics is that they have unintended consequences that are often harmful to other people. And so, if I, as a clinician, for instance, I choose to spend more time with a particular patient, then every patient after that will have to wait longer to see me. And while patients understand when I do that, and they often tell me so, it's also unfair with with the staff that works with me, who may be now late for their kids' soccer game or whatnot. And so, this idea that we can individually make a difference for us or for our patients is problematic, but also leaves the system intact. So I will have to keep doing that ad infinitum, and we don't have all that energy. So it's better to change the system. And I know that it might feel like too much in the future and too big of a hill, but that's why we are talking about a revolution, not because it's a nice a word, or in the case I'm from Peru, it's not a nice word. I mean, when we have revolutions, people die, and it's usually the most vulnerable. But we're talking about a nonviolent movement to fundamentally change healthcare. We're not talking about how we make some improvements over here or over there. And the other thing that we have to keep an eye on is when people say, well, okay, there's no time. So what might we do? Oh, let's bring technology in. Let's do some task shifting. Give it to people with less and less skill. And what we're seeing there is a Taylorism, is a further industrialization of healthcare, in which, oh, we can have the clinician do the cognitive things, but we have some other person do that more the emotional support, and we may have some community health people do some of the ongoing support and coaching, and we've now cut it into so many pieces that we continue the fractionation of the healthcare system now into primary care without having the ability, the courage, and the collective effort to fundamentally change healthcare in the first place. So I'm not a reasonable person. Annie did not invite me here because I'm reasonable, but I think it is unreasonable to pursue improving on a system that simply is no longer designed to care.
thank you for that. Going back to, I feel like I just want to keep chatting, but I'm going to go back to the questions. We have one in the Q&A, and I'm going to try to regroup maybe one or two together. But there seems to be a tension between physicians' need for emotional self-preservation and their adherence to patient-centered care principle. So how can this tension be addressed to ensure both well-being of providers and the prioritizations of patient needs? And I think that may align with another question that asked about how do you address the other element of the quadruple or quintuple aims in regard to care?
So is the question about meeting the demands of patients? Is that did I get that?
So how can the tension be addressed between the emotional self-preservations of physician and their adherence
Yeah.
Centric care
Yeah,
principle.
so it almost is it's almost framed as if we were to listen to people and work with them to form plans of care, that somehow is going to be at the expense of our own health as clinicians, right? And it seems to be like a zero-sum game, that the more we give, the less we have. And I'm making the case that that is not the case. So when we look at why people get exhausted in healthcare and why people uh, leave healthcare because of burnout or whatever, oftentimes it's not because they care too much. Oftentimes is that they couldn't care enough because, or they couldn't care well enough, or they couldn't meet their own expectations of the care they needed to give because of the conditions in which they had to work. So the solution to that is not to become less patient-centered. The solution to that is to change the conditions of work. The second part of that question assumes that meeting every patient's demand is what we mean by patient-centered care. And that is not what I'm proposing. I'm a big, and Anya and I have done work together on shared decision-making, and I don't see shared decision-making as a shopping experience where you lay out product and the patient go, oh, I like a little bit of that and some of these, and I feel like that one. And I know sometimes it feels that way, and sometimes our colleagues behave as if it was that, but that's not it. It is not a shopping experience. It is not a selection of what I want. Care is about alleviating suffering and enabling flourishing. And how a given person will get to that point is something that requires a combination of self-awareness and participation and generosity and involvement and openness from the part of the patient, and similarly from the part of the clinician. It's collaborative work. Sometimes patients are not up to the task. Sometimes clinicians are not up to the task. But if we create the conditions for that to happen, that may be more likely than not. At the moment, even if you are up for the task, to get that within the current healthcare system is really a heroic act, and it shouldn't be. But I reject the notion that patient-centeredness is in conflict with clinician well-being, as I reject the notion that patient-centeredness is in conflict with evidence-based care. I also, and I'll finish with this very quickly, is that you're asking difficult questions, and so the answers have to be long. It's when a clinician is just starting, following the guidelines, following the protocols is reassuring to them and safe for the patients. Being overly rigid when you first start might not be avoidable, frankly. But usually when you start, you have older colleagues that can support and help you. But everybody's so busy that the older colleagues are no longer available to properly mentor the junior ones. And so those junior ones just go through their early part of their career, following guidelines, checking boxes, and meeting requirements. And that is not the kind of career they sign up to have. So we need to make sure that what we see as the baseline, as the floor performance that the guidelines set up, on top of which you build the individualization of care for each patient, that doesn't become the ceiling performance, that is as much as you're willing to do for someone, because that is not going to meet the needs of the patients, is going to contribute to anger and conflict, and is going to disappoint not only the patient, but the clinician, who would feel that they cannot be patient-centered and have a good life, which is something that I reject.
Thank you so much, Victor, for such an inspiring talk. I feel that this has answered a lot of the questions that were asked. We unfortunately are running out of time, but we will try to compile some of your questions and make sure that maybe working with Victor to address some of them in when we provide a summary of this conversation. So Thank you again, Victor. Join us next month when we have, as I mentioned earlier, Stephanie Bartlett, who will continue this thinking in terms of how we can work together and how do we work collaboratively to achieve this kind of work next month. You've mentioned the next generations, you've mentioned the junior. I'm going to thank everyone for joining us, and I'm going to ask our fellows. So thank you, Victor, for actually taking the time to meet with our next generations of researchers and our junior fellows to continue these discussions on care and kind care. So thank you, everyone. See you next time. Fellows, please stay online with us.